good afternoon, or good evening, depending on where you're joining us from. We are pleased to welcome you to today's webinar. I'm Radolf Norte, and I'll be your moderator for this online event. So today's webinar is the first of a two-part webinar series, and the series has been organized as a collaboration between ISSUP Global, the South Africa International Technology Transfer Center, that's the ITTC, and the University of Cape Town, South Africa. The session today focuses on an introduction to screening, brief intervention, and referral to treatment for substance use, which we'll be commonly referring to as the SBIRT, and screening tools for substance use. So in this, we'll be looking at what are the components of the SBIRT. We'll try to understand the goal of the SBIRT model, and then alongside contextualize and highlight the significance of SBIRT integration into the primary healthcare. So before we get started, I'd like to go over a few things to ensure your participation in today's event is smooth and seamless. Firstly, we've made provision for Spanish interpretation. This is available throughout the entire session. The details have been posted in the chat, so I think you can refer to the chat window if you'd want to connect to our Spanish interpretation. You'd find the link and the corresponding instructions in there. You can also submit questions live to our presenter. These questions can be posed later by typing them into the questions pane of the webinar interface. Anytime during the presentation, feel free to type these questions in the questions pane. A recording of the webinar will also be made available for you to watch on demand after the event, and a certificate of participation will be emailed to you 24 hours after the webinar. So now a little bit about our distinguished speakers. Shahima Ali is our first speaker, and she serves as the Assistant Director of the South Africa International Technology Training Center. That's the SAITTC. She oversees training, curriculum development, and coordination. In this role, Shahima develops and adapts curricula to be disseminated nationally. She trains professional and non-professionals across South Africa in motivational interviewing and screening, brief intervention, and referral to treatment, and is part of a few research projects at the University of Cape Town. The second speaker will be Mr. Fergus Ashburner. Fergus Ashburner is a clinical psychologist by training. He's the course convener of the postgraduate diploma in addictions care at the University of Cape Town. He works in both inpatient and outpatient settings, assisting patients with recovery from substance use disorders. Fergus is a senior trainer on the SAITTC model in motivational interviewing. So I'd hand over now to our speakers, Shahima and Fergus. Thanks again for joining us.
Thanks, Radolf. Yeah, good morning, good afternoon, wherever you are in the world. It's our pleasure to be part of this webinar series. As Radolf said, Fergus and I are based at the University of Cape Town with the South Africa International Technology Transfer Center, and we are part of the broader network, global network, and we are funded by US Department through the Colombo Plan Advisory Program. And yeah, we are happy to be part of that international network. So welcome to this two-part series. Fergus, hi.
Hi, Shahima, and thank you, Radolf, for that intro. I'm excited to be here, everybody, and yeah, excited to see what you can gain from the exposure to the SBIRT model.
Yeah, thanks, Fergus. So this week it's myself and Fergus. Next week, our colleague Nurain Tisika will join us. But yeah, we'll walk you through this. We do want to keep this quite practical. So when we go through today's session, we will throw out a few poll questions. So please engage us on that. I'll also play a video, a training video where you can score along with the role play. So we want to keep it quite practical. And as Radolf mentioned, please, any question you have for us, put it in the chat. We will try and answer it throughout this session. Okay, so for now, I will be sharing my slides, and then we'll get through the SBIRT training. Let me just get to my slides. People online, so I'm wondering where in the world everybody's from, and if they can maybe in the chat also tell us.
Yeah, that would be great to see where everybody's from and say hello.
Yeah. Okay, Fergus, are we all set? Cool.
All good, looks good.
So like we said, this is screening, brief intervention and referral to treatment. And for the first part, we're going to focus on step 1, which is screening. But I first want to take a few steps back to just introduce you to what SBIRT entails and what the model entails. So welcome again. You now know who we are, so welcome to put in the chat where you are all from. So what is SBIRT? SBIRT is a comprehensive, integrated public health model approach to the delivery of early intervention and treatment of services for persons with or at risk of a substance use disorder. SBIRT is an evidence-based approach which has been studied globally, and we are from South Africa, and there's lots of evidence within our country that shows that the SBIRT model does show some effect on reducing substance use. Did my focus in my screen still showing?
Yeah, the slides are not showing. I'm not sure what happened there.
It looks like it kicked me off. Let me just re-share that then. Sorry for the technical glitch. Okay, there we go. So SBIRT was initially based in public health setups, but SBIRT can be integrated across various services. So it can be in primary health centers, emergency centers, in schools. So you could use this SBIRT model in a school setting where you will screen for somebody who is possibly at risk of a substance use disorder. And the aim of SBIRT is to screen and then intervene. So intervening early means that when we catch somebody at an early stage of their use, we can then come up with a plan and assist the person instead of waiting till the person is at severe risk. So we want to be able to prevent the person from using at more higher levels of risk. So SBIRT is screening, brief intervention and referral to treatment. So screening is like a finger prick test. So when you go to the doctor and they check your sugar levels, they do a quick finger prick and they check your sugar levels. And that is what this screening entails within substance use. So it quickly assesses the severity of risk and then what is the level of intervention or treatment needed. Brief intervention, it focuses on a counseling approach that increases the insight and awareness of the person's substance use, and it also helps them to motivate them towards some sort of behavior change. But we'll go through the brief intervention and referral to treatment next week, and how we go about doing the referral to treatment. Okay, so the SBIRT or the model or the method is this. We screen, we use a screening tool, which is a 5 to 10 minute process of asking various questions around substance use. And then based on the scoring, will be identifying at which level of risk the person is at. So if somebody is not using any substances, they will be at no risk and they will score 0. And so if you follow the tree and the method, you'll see with no risk, no further intervention is needed for substance use. However, if they're scoring at other levels, which is low to moderate, moderate to high risk, or severe dependency, the interventions will vary, and also based on what substance the person is also using. So if somebody is low to moderate risk, there is brief advice or brief intervention needed. And then if they are at high risk, a referral for specialized treatment is recommended. So still using a brief intervention to raise the awareness before doing the referral is important at that stage. So what is the primary goal of SBIRT? So the screening that we do for substance use at this point, using the tools that I'll introduce shortly, the goal is not to make a diagnosis. So when we're looking at substance use disorders, it is a DSM-5 mental health challenge. And so a psychiatrist, a doctor, psychologist, they are able to make a diagnosis using the DSM. However, with SBIRT, we are saying use the screening tools It doesn't matter what your background is. So if you're a social worker, a nurse, community healthcare worker, a lay counselor, registered counselor, you can use the screening tool in order to identify at which level of risk the person is using substances at. So anybody can basically then screen for substance use. So we're just identifying quickly using the tool in order to know, okay, is this person at risk of a substance use disorder or not? And if they are, at which level of risk are they? So it's important to note that it's not a diagnostic tool. It is just identifying early what is the level of risk of their substance use. So again, let me just go back into the step one, which is the S of SBIRT, which is screening. So screening is a universal approach. That is what the SBIRT model entails. So when you integrate SBIRT into your facility, you use this universal approach. So anybody that enters your facility through your doors will get screened for substance use. So we're not going to be picking and looking like, oh, Fergus, you look like you're using alcohol, let's do a screen tool. No, we're going to screen everybody that comes through the door and use that universal approach. And this way, we also don't miss anybody that might be using at risky levels. So ideally, we want to treat our clients holistically. So when somebody is entering a hospital setting, you want to integrate screening for substance use and alcohol use as well. Just like we want to integrate screening for depression, anxiety, as well as any other health challenges. So SBIRT is saying that we need to use this universal approach, do an initial screening, and then identify at which level of risk the person is using. The questions are usually simple, brief. Some screening tools can take 2 minutes, some can take 5 minutes, so just depending on which screening tool you are using. It is usually a single event. Some screening tools ask around the past 12 months. Other screening tools ask around the past 3 months of use, and that can be repeated later on in the year. Screening can be done through your counselor, your therapist, so in an interviewer method, or self-administered. And I'll tell you a little bit more about that when we go into the screening tool that I'll be training you on. So there are various validated screening tools for adults and adolescents globally. I'm just showing you the ones that are most used in our country, in South Africa. I would be interested to hear in your settings, what is the tool that is used mostly, and you can put that in the chat and identify which tool you are currently using. So we've got the audit, which is the alcohol use disorder identification test. This screening tool only assesses the level of risk for alcohol use. So if you're doing the audit, you need to do the DUDIT, which is the drug use disorder identification test. So we want to be able to screen for all substances, and therefore you'll have to do 2 screening tools, which might take a little bit longer. The one I'm going to introduce you today is the ISSUP, which is a World Health Organization screening, alcohol, smoking, and substance involvement screening test. It is a comprehensive tool that covers all substances, including tobacco and alcohol. Just to note that these are validated for 18 years and older. With the ISSUP, there is also the ISSUP-Y, which looks at 14 to 17 and 10 to 13. So there is an adolescent version. Some other tools that people might have come across is the CAGE, which is for alcohol. It's just 4 questions. It's very quick. There's the DAS-10, which takes a little bit longer, screening for drug abuse, and then the GAIN or the GAIN-SS. Okay, Fergus, do we have any comments or questions on those?
I think just to note that the audit, DUDIT, and assist are the 3 tools that make up the SBIRT model, or the screening tools that form part of the SBIRT model. And then the CAGE, DAS, and GAIN are other validated screening tools, but they don't form part of the SBIRT model.
Okay, cool. Thank you. So now I'm going to hand over to Fergus before we get into the actual practice of using a screening tool. And Fergus is going to go through some of the psychoactive substances, which are quite important to understand when we're asking these questions. I'll hand over to you, Fergus.
Thanks, Shahima. Okay, great. So we're going to have a look at these psychoactive substances. What is important to know around any psychoactive substances, whether it be alcohol or the other drugs, is that they affect your body's central nervous system. And they can be, they're not always are, but they can be addictive. So what we mean by they act or affect the body's central nervous system is that they change how people might behave or perceive what is happening around them. And so this is done by altering mood or emotions, thoughts, sensory perceptions or behaviors. So what can happen, and you'll find that if you work with people who are struggling with substance use disorders, is that they might use the drugs or alcohol to numb some of their emotions, but also sometimes to amplify a joy that one would feel after their favorite soccer team wins. So it can numb the anger that comes from the conflict with their spouse, or it can also augment a sense, a pleasurable emotion that they don't want to let go of. It can also impact your thoughts. So people can often drink, for example, so that it quietens their mind. Unfortunately, what can also happen is that can lead to some sticky thoughts that they struggle to let go of and ruminate on. Some drugs alter sensory perceptions, so they might alter the perceptions of color or illusions in the immediate environment. And then quite often it impacts the person's behavior and takes out insight and judgment in a person acting appropriately in a particular context. So an example of that is when people drink increasing amounts of alcohol, they become disinhibited and might say or do things that they wouldn't usually do when they were sober. So one really has to understand how drugs and alcohol might impact a person, the way in which they manage their emotions, the way in which they manage their thoughts, and the way in which they might behave once they've ingested drugs and alcohol. So it's important, once we understand that drugs and alcohol have psychoactive effects, so they act on our central nervous system, it's important to have a good lay of the land of the substances, both legal and illegal, that are in your context, because you're going to be seeing them in your places of work, whether it be at a clinic, whether it be at a hospital, whether it be at a drug rehabilitation center. We have to know what's happening in our context that we're working in. So we'll have a bit of a deep dive into some of the psychoactive substances that you might encounter or might be encountering. They are the illegal substances. So that would be alcohol, inhalants, caffeine, nicotine, prescription or over-the-counter OTC medication like benzodiazepines or codeine pain medication. And then in the South African setting, marijuana or cannabis. You then also have illegal substances like cocaine, methcathinone, which is cat, heroin, methamphetamine or crystal meth, ecstasy, mandrax or methaqualone. What is important to note and internalize is that just because a substance is legal, it does not mean that it is safer than an illegal substance. So what we see in the South African setting is that a lot of the drug rehab units, there are a lot of people who are managing or trying to achieve recovery from alcohol or marijuana and cannabis. And I think a lot of us will be able to identify with having a caffeine addiction, which is commonly found in coffee. So just maybe put in the chat if there's any drugs that you can particularly identify in your context, if there's a problem. Something to also note is that in each context or on the street, the drug has a street name. So for example, cocaine might have a street name Charlie or below. And very often, the people who are using and consuming these drugs might only know the street name. So it's important to have, those code words or terms for the street drug, so that you know what you're dealing with and how they might impact on the central nervous system. So maybe if you can just put in the chat some of the names that drugs can go by in your context. Psychoactive substances. So using a psychoactive substance is different than being addicted to the psychoactive substance. So just because you come across someone who is utilizing codeine, it doesn't mean that they are addicted or who have a substance use disorder. In fact, a lot of the addictive psychoactive drugs are used in modern medicine today to address particular issues. So for example, a stimulant medication like Ritalin or Adderall is used to treat attention deficit hyperactivity disorder. An example of an opioid that is used medicinally. So people are prescribed codeine medication if they have pain or experiencing pain in their body, or codeine-based cough mixture if they have to treat symptoms of cold and flu. Similarly with morphine. So it's not to say that because a person is using these substances that they're addictive. However, they need to be quite careful to stay on prescription. So now we'll look at the drug classes or drug classifications. So it's important, this is important because then we know how the drug acts on the central nervous system. We'll keep it quite simple with an explanation now. Stimulants stimulate the central nervous system, and they generally lead to an increased activity and a sense of euphoria when the person ingests the drug. The drugs that form part of the stimulant drug class are methamphetamine. In South Africa, it's commonly known as TIC. Another word for it is crystal meth. Another stimulant is cocaine or methcathinone, known as CAT. And then some, drugs that are commonly known, and I think a lot of us will have exposure to them: nicotine, which can be found in cigarettes, and caffeine, which can be found in coffee, Coke, or energy drinks. Then we have depressants. So depressants depress the central nervous system and normally have a calming effect on the person and almost slows them down. You will find that in alcohol. You'll find other drugs that form part of the depressant classification are Mandrax or methaqualone, which is well known here in the Western Cape. Barbiturates, which was a medication to treat insomnia and headaches. It's not very common in South Africa, but it might be in your part of the world. And then benzodiazepines. So benzodiazepines are psychiatric medication prescribed by psychiatrists or doctors to treat anxiety. They are very common now, and you'll see they come in the form of diazepam, Xanax, and I think are going to be a real problem. So one must really be on the lookout for that. Other depressants or opioids are heroin, morphine, Percocet or OxyContin, which are opioid-based medications, and then codeine, which can be found in pain medication and cough mixtures. These are also popular. They can be quite popular in music culture. You'll see them lean, where people mix some soda with a cough mixture and then sip on that. And then there are hallucinogenic drug class, which impacts leads to differing perceptions when people ingest the drug. That is cannabis, marijuana, ecstasy, LSD, and then magic mushrooms. So having an intimate knowledge of those 4 drug classes will be important for a person making their way into treating or screening, assessing, and treating substance use disorders and utilizing the SBIRT model.
Fergus, so can you hear me?
Yes.
So I've just been browsing some of the comments and questions, and some people have mentioned fentanyl. And then there's a question for you about alcohol. Can alcohol also be a stimulant? The person is saying, I have noticed that it causes fights in some instances.
Okay, so I'll answer the fentanyl question. I believe the fentanyl is a synthetic opioid. So that falls in the depressant or opioid classification. It's quite a new drug and was meant to be prescribed to address pain, but is quite highly addictive because of the concentration that it's significantly stronger than heroin. So that leads to its high addictive potential, and one can quite easily lead to overdose. I think initially the impact of consuming alcohol can have a disinhibitory effect on people, and they get courage and they might act out more socially. It's called a social lubricant. But I think as you consume alcohol over a longer period of time, then it acts as a depressant. I think what the person is alluding to is that when people fight, it can often amplify difficult feelings that the person is having. So if they might be an angry person and they drink on that, it might amplify their anger and lead them to get into fights. That's just one mechanism that I can think of to that comment.
Thanks, Fergus. And then I just saw some more comments around people in South Africa mentioning Niope. And so if we can just maybe say something about that.
Sure. So Niope is a mixture of, well, I mean, it's not a perfect mixture, but it can be heroin and cannabis, and sometimes they can also include methaqualone or mandrax. So it's a combination of those drugs. It's normally considered street grade and very quite addictive because of the mixture of those psychoactive substances, and quite commonly found in the South African setting. So those screening and treating substance use disorders in the South African setting must be aware of a Niope or Wunga, which is a combination of drugs that people can become addicted to.
Yeah, and what you're saying there is that when we do these screening tools, when we say, for example, heroin, the person might not understand what we mean. So it's important to also know some of the street names and other versions of the substance.
Absolutely. I think very often people come in and they'll use the street names and the contextual names for the drugs. And if you don't know them, you won't be able to, in your mind, classify and understand how the drug acts on the person and how the person functions on it.
Yeah, so yeah, it is quite important then to have some idea about the substances within your communities and the effects thereof as well.
Absolutely.
Okay, so thank you, Fergus. I think you've covered the main substances in what most people would come across. I thank you for that. But I was thinking, let's pull up some poll questions just to check that people are still with us and if they've understood what we've just discussed before we get into the ISSUP screening tool. So I was thinking, Fergus, we could ask them the question around what drug class does alcohol belong to? If we can give them that poll question, and then we can ask them also which screening tools they are currently using in practice. I think I need to stop sharing my screen and then. So yeah, so people please just choose the most appropriate answer that you think there is. It's just a quick poll. Okay, we're at about 50% of votes. We will close that soon. Okay, Fergus. So it seems like 89% of, can you hear me, Fergus?
I can hear you, Shima.
it seems like 89% said that alcohol is a depressant, 1% said it's an hallucinogen, and 11% said it's a stimulant. What are your thoughts?
Great. So well done, guys. I think the majority of people selected that alcohol was a depressant. And yes, it's a depressant. It depresses the central nervous system. So yeah, good job on being able to identify that.
So they're following us still. They're still with us. Okay. Then my next poll question is, what screening tools do you currently use daily, if you are using any? It's just to give us a sense of what you're using in your practice if you're working with clients. It will come up soon. So are you using the audit, the do it, the assist, cage, craft, or none? See the votes coming in. About 40% of people have voted. So we couldn't add the none option, but if you're not using any, you can just tell us in the chat if you're using something other than these. Okay, we'll just give it a few more seconds. Okay, we'll stop the poll there. So Fergus, it looks like 20% of people are using the audit. 1% is using the do it. A majority of 58% is using the assist, which is great. And then we've got 18% of people using the cage, which I also thought majority would use. And only 2% is using the craft. So that's quite a spread, with the craft and the do it getting the least people using it.
I think that's great. I think the assist is such a comprehensive tool. And I'm also then pleased that people get exposure to the do it, because the do it and audit can be used complementary alongside the assist for really great comprehensive screening. So either you're getting a refresher or you're getting some new exposure, which is good.
Yeah. For those who are not using any of these screening tools, you can put it in the chat. Perhaps there are other tools that people use globally that we don't use in South Africa, but that you use in your setting. So quite curious to also see what else is out there. Okay, let's move on. I'm going to screen share again. Okay, thank you for the poll questions and for answering that. Just going to close the polls and then let's get back to, okay, great stuff. Thank you everybody for answering the poll, so we know we're all still there and following along. So, okay, so now we're going to go into the World Health Organization assist screening tool. As mentioned, it's the alcohol, smoking and substance involvement screening tool. So majority of you are using the assist. So as Fergus said, this is most likely then going to be a refresher. Or I might just show you something that would be useful for you in your current practice. So before we do screening with SBIRT, we want to let our clients feel at ease, because it's not always easy to speak about what somebody is using, especially if it's illicit substances. People don't always trust as therapists or social workers or counselors with the information. So we just want to set the scene, and this is just an example. So before we do the screening, we said, I'd like to ask you some questions that I ask all my clients. These questions will help me to provide you with the best care possible. And as with all medical information, your responses or your answers are confidential. And then you can go into what confidentiality is, because there are limitations to confidentiality, but also just assure your client that if you are feeling uncomfortable, that they can let you know. So when asking these questions from these screening tools, clients are allowed to say, I don't want to continue any further. We don't force screening upon our clients. So, okay, let's get into the assist. So the assist is a very comprehensive tool, as Fergus mentioned. It is developed by the World Health Organization for its use initially in primary health care. It has been studied across the globe in 8 different countries. It's found to be culturally appropriate, and it's quite comprehensive in that it asks about around 10 substances with 8 questions. So it looks at tobacco use, which a lot of other tools exclude. It asks around alcohol use. You saw earlier the audit asks around alcohol use, but the DUDIT does not, so you need both. It asks around cannabis use, amphetamines, opioids. And then if you look at the tool, it also has another category. So in South Africa, and I'm sure across the globe, people are very, very creative. And sometimes we don't even know which category the substance falls into when we come across somebody using something we're not familiar with. So in the tool, there's another category, and you can actually insert that and assess that as well. So what this tool does is it gives you a level of risk for each substance across the spectrum. And it gives you information on hazardous use, harmful use, and possible dependence, and it includes injection drug use. So it looks at the past 3 months, so it's quite recent use, where some other tools ask you about the past 12 months, and I can tell you, if I must think back to January this year, I will not be able to tell you what I did. So I like that it looks at the past 3 months, and then there are certain questions that are lifetime use questions. I'm not going to go into this because what this helps with is if you're doing the paper-based version. So today, I'm letting you know that at UCT, under the South Africa ITTC, we have taken this 12-page screening tool and put it on a web app platform. And I'll ask the colleagues assisting to put the URL in the chat for you so you can open it. And so you no longer have to calculate the scores, and everything is automated on this web app tool. And then you'll get this scoring guide with all the screening, all the substances, as well as the scores. But I'll show you a little bit more about that now. So I want to get straight to the tool because I see we are running out of time. Time just flew by. But again, just to tell you the benefits of the WHO Assist, it also includes a brief intervention component. So there's a treatment approach. You don't have to be a specialist to use the tool and to do a brief intervention. So what I'm going to do is I'm going to put up a QR code. If you can just scan this QR code with your phone, tablet, 2 options. There's a self, and then you will see that there are 2 screen options. I want you to use the self-screen option because that does not need the login details, so it just goes straight in. So basically, with this web app tool, you will need a date of birth, so you can put in a date of birth that's older than 18, and then we will follow the role play video shortly, and then we'll score it using the video. About the tool, it's anonymous, so you don't put the client's ID details, you don't put the client's first name or surname. We only need a date of birth just to direct us to the correct version of the tool. So we are going, this is just an example of how the tool looks. If your QR code is not working, you can type in this URL at the top, the https assistscreening.uct.ac.za. If you want, take a picture of this and then you can type it in on your phone because we're going to screen the role play shortly. Okay, so this is just showing you an example, but you will see all of these screens when you score the tool. So you can go into the self-screen version of the tool in the meantime, select a date of birth, and then just choose a random demographic question answers so that we can get to the actual questions of the assist tool. So open it up now, and then you'll get to this screening start page, which is just screening question 1. Then just wait over there because we will play a video and you will listen along and score the client by just selecting the answers that you're hearing from the client. Okay, I hope that's clear. Let me just check if there's anything in the chat. So if you've got it, if you're at the screening tool now, self screen is where you're going to select, put in random demographic details and get to this page, which is question 1 of assist screening. Okay, You'll see at the end of the screening tool, there will be a summary. Take a screenshot of the score because I'm going to ask you what scores you got for the client, Samantha. Okay. At the end of the screening tool, you are allowed to send yourself the screening score feedback card with putting in your email address or your client's email address, but it doesn't store in the system, so everything still remains anonymized. Okay, so we are going to practice now. We are going to show you the video, and then I just want to stop. Fergus, can you see me?
Can see you, Shahima.
Okay, so I hope everybody is on the page, the web app assist, and that we are now ready to screen the client, Samantha. It is a role play, so it's not a real client. We're just actors in the video. So as the therapist is asking the questions of the assist, you will be using the web app tool to capture the responses of the client. And then at the end, you will get a score, and I will ask you what your scores were. Okay, let's listen to the video, or watch the video and score along.
Hi, Samantha.
Hi.
Thank you for being part of this brief interview today. Today I'll be asking you questions around your tobacco use, alcohol, and your use of other drugs.
Okay.
Okay. So I'll move into question one. Question one is, in your lifetime, which of the following substances have you ever used? Tobacco products?
No, I don't smoke. It's not good for you.
Okay, no. Alcoholic beverages?
Everybody drinks.
Okay, so that's a yes. Cannabis?
Yeah,
Yes.
I do smoke.
Okay. Cocaine?
No,
Crack?
too expensive.
No. Amphetamine type stimulants like speed or ecstasy?
I've used ecstasy before.
Okay, so yes. Inhalants like glue or petrol?
No.
No. Sedatives or sleeping pills like Valium or Rohypnol?
No.
Okay, no. Hallucinogens like LSD or mushrooms?
Oh yeah, I've done mushrooms before.
Okay, that's a yes. Opioids like heroin or codeine?
Yes, heroin.
Okay, heroin. And then any other substances? So in South Africa we have mandrax.
No.
Okay, so that's a no. Okay, so you'll see for the next questions, question 2 to 5, we have a particular response card. The options are never, so not used in the past 3 months, once or twice, which is 1 to 2 times in the last 3 months, monthly, which is 1 to 3 times in 1 month, weekly, which is 1 to 4 times per week, and then daily, almost daily, which is 5 to 7 days per week.
Okay.
Okay. So, question 2. In the past 3 months, how often have you used substances that you've mentioned? The alcohol?
I would say monthly.
Okay, monthly. Cannabis?
About the same. Also monthly.
Okay. Also, again, in the past 3 months, how often have you used amphetamine type stimulants?
Oh no, I haven't used that for a very long time.
Okay.
The ecstasy was when I was like a teenager.
Sure, okay, a while ago. Okay. In the past 3 months, how often have you used hallucinogens?
Oh no, the mushrooms also like a while back, so not recently.
Okay, a while back. And then again, in the past 3 months, how often have you used heroin?
That is, I'm using that around daily or almost daily.
Okay. Then, question 3. Again, you'll see it's in the past 3 months. During the past 3 months, how often have you had a strong desire or urge to use alcohol?
Once or twice.
Okay, once or twice. Again, during the past 3 months, how often have you had a strong desire or urge to use cannabis?
It was also around once or twice in the past 3 months.
Okay. And then, how often have you had a strong desire or urge to use opioids or heroin?
Yeah, that I need to use daily,
Okay.
almost daily.
Sure. Okay. Thank you. So we're going to move on to question 4.
Okay.
It's also during the past 3 months.
Okay.
So during the past 3 months, how often has your use of alcohol led to health, social, legal, or financial problems?
Yeah, my boyfriend and I are always fighting when we drink, and that's like monthly maybe.
Okay, monthly. During the past 3 months, how often has your use of cannabis led to health, social, legal, or financial problems?
Oh no, never. That's not a problem.
Okay, not a problem for you. During the past 3 months, how often has your use of opioids led to health, social, legal, or financial problems?
Yeah, that's a lot more. That's like daily almost. Lots of problems with that.
Okay, so it's causing strife in your life.
Yeah.
Okay. Then we're going to move on to question 5. Again, it's within the past 3 months. During the past 3 months, how often have you failed to do what was normally expected of you because of your alcohol use?
That maybe happened once or twice when I couldn't do what I needed to do. So yeah,
Sure.
not
Okay.
more than that.
Once or twice. During the past 3 months, how often have you failed to do what was normally expected of you because of your use of cannabis?
No, never.
Okay, never. During the past 3 months, how often have you failed to do what was normally expected of you because of your use of heroin?
Yeah, that's I would say weekly.
Okay, weekly. Thank you. So we're going to be using a new response card now, Samantha. This response card, as you'll see, will be used on questions 6 to 8. And the responses are no, never. Yes, but not in the past 3 months. Okay. And yes, in the past 3 months. So the distinction is whether it's recent 3 months or beyond 3 months. Okay. So question 6. Has a friend or a relative or anyone else ever expressed concern about your use of alcohol?
Yes, but not recently.
Okay.
So not in the past 3 months.
Okay, thanks. Has a friend or relative ever been expressed concern about your use of cannabis?
No, never.
No. Okay. Has a friend or relative ever expressed concern about your use of amphetamines?
No, that's long ago.
Okay,
People don't even know about that.
Okay. Has a friend or relative ever expressed concern about your hallucinogen use?
No.
No?
Those were fun times.
Okay. Has a friend or relative ever expressed concern about your heroin use?
Yeah, my mother, she's always nagging. So that is, she's concerned, I suppose. And that's happening now, recently.
Recently. So it's yes and in the last 3 months. Yeah. Okay. Thanks, Samantha. Okay. Then question 7. Have you ever tried and failed to control, cut down, or stop using your alcohol?
No, that's not a problem.
It's not a problem. Okay. Have you ever tried and failed to control or cut down your use of cannabis?
No.
No. Have you ever tried and failed to control, cut down, or stop using amphetamines?
No.
No. Have you ever tried and failed to control, cut down, or stop using your hallucinogen use?
Oh, no, never.
Awesome. And then have you ever tried and failed to control, cut down, or stop using heroin?
I did try. That was like about 6 months ago when I was pregnant, but I lost my baby.
Okay.
So I haven't tried again to cut down.
Sure. I'm sorry to hear that. So just to qualify, it's yes, but not in the past 3 months.
Yeah.
Okay. Then we're on to question 8, which is the final question. Have you ever used any drug by injection?
I have with my boyfriend. A couple of weeks ago, I gave it a try. It was just once off, not again.
Okay, so is it yes and not in the past 3 months?
Yes, but recently, so in the past.
Okay, so thanks for that. Okay. All right, thanks, Samantha. Thank you for going through these questions with me. If you can just give me a couple of moments so that I can tally up the score, and then I'd like to discuss the feedback with you.
Okay, thank you.
Samantha's total score for alcohol on
Okay, so that was the assist, web assist. I hope that you managed to to play around with the tool and forgive Fergus my acting skills. We're not trained. So that's just a role play that came up with. So the training video was about 8 minutes long. And the reason for that is because we went through quite slowly that you can go through the questions and for training purposes. But ideally, when you do the web app screening tool yourself, it can actually take like 4 to 5 minutes if you're just going through the questions and then in the scores and then taking the step further. So I guess love your acting.
Yeah, thanks, Shima. I'm not sure if you can hear any echo when I talk.
No.
But yeah, I'd like to echo what you were saying. Once you are familiar with the assist, you can really get through some of the items quite quickly. And when you open up the discussion with a client, there's rich description that the client gives you to utilize in the brief intervention that you'll be doing a bit later on.
Okay. I'm hoping now that it says that I see in the comments plus that my sound is echoing. I'm not sure what's happening. Because I didn't change anything.
Yeah, it's tricky. Potentially maybe mute and then unmute.
Yeah, I just did that now. This will sound like an echo.
Yeah, there's a bit of an echo. I might try and kind of take over if it's an issue. I think we've got a few minutes.
Okay, sorry about that. Fergus, I'm going to hand over to you.
Okay, so I think what we'll do is then we'll move to the poll, the final poll, and we'll give an opportunity for the attendees to have a look at the poll regarding their score that they achieved, and we'll take it from there.
Okay, so that's switching off and on is still echoing.
Yeah, there's still a bit of an echo. Yeah. Yeah, so maybe what we can do is we can try and just shift into the poll and okay. So you should see the poll coming on your screen now. So it's based on the assist screening that we just did. So for Samantha, what did she score for opioids? You get 4 options. Did she score 12? Did she score 45? Did she score 22? Or did she score 35? Okay. So I can't see the answers my side, but I will just be talking to some of the scores. So if you scored, or I think we can play the rest of the video. So if you had got the score of 35 for Samantha, then that would be the score that she attained on the assist. So a score of 35. Hi, Shima. A score of
Can you hear me now?
Now you're back. Welcome back.
Sorry for that gremlins, but continue. I'm here to listen.
Right. So on the assist, Samantha would have scored 35. That would mean a brief intervention and a referral for treatment. So what that would mean is that the assist has captured risky substance use in and around heroin, and an appropriate referral to a clinician who can treat a substance use disorder is important. So it would be really great to have a scan and a lay of the land in your context or town where a district hospital or professionals, and so this can be quite important, where professionals who are equipped to treat substance use disorders can receive the referral of Samantha and be able to start working on either a harm reduction approach potentially to help her lower the risks of her heroin use disorder, or even, with opioid-assisted therapy and potentially in a longer-term abstinence from heroin. So it's going to be really important to have a scan of the resources, the substance use treatment resources in your area. Particularly professionals, not all professionals are equipped to treat substance use disorders. So it might be a good thing to go off into your community and to find those resources. And if not, potentially try and capacitate professionals to be able to treat substance use disorders. And yeah, and I think probably, especially if this is your first exposure to the assist, you might need to practice utilizing the assist. Shahima?
Thank you, Fergus. Did they manage to get the score for?
So I'm not sure because I couldn't see the outcomes of the polls. Okay, yes, sorry, now I can see. So 22% were able to get the score of 35. 45 participants got, yeah, the score of 22. So it might require a little bit of practice, not to worry. The first time that you get exposure to the tools, they can be a bit tricky. But when you go over it in your own time and you practice the tools and you get more knowledge, you're more likely to become more competent utilizing the tool.
Yeah, and then what she also scored for was alcohol, and she scored 19 for alcohol, which is a moderate risk score, so she would receive a brief intervention for that. And then she also scored 6 for cannabis, which also falls into that moderate category where a brief intervention is needed. So what you would have seen also with the tool is it asks around injection drug use, which other tools do not ask. So I really like this tool. It's really comprehensive. Okay, Fergus, it is 2 o'clock South Africa time. We are running out of time, but I just wanted to scan to just check if there was any questions that we could answer right now. I think, okay, there's a good question from the Philippines. Can we use the link for assist freely in our country? Please go ahead and use it. It does cater for South Africa, Africa, and beyond. So when you capture the demographic information, you can choose for outside of South Africa. So the other benefit of it is if you send me an email and want some more information, I can share that with you. And so anybody can create a profile. So it doesn't matter where in the world. If you're a practitioner, create a profile and you can have all your data linked to your profile. So if you need some information around how many people you screened in the past year, drop me an email and we can see what we can do. It's freely available. You just need a bit of data to obviously use the tool, but it's not very much. Okay, and then I see some people had some challenges with seeing the video, and I think it probably comes down to bandwidth. I do apologize for that. Let me just check if there's any other questions for us, Fergus, and then we can wrap up. If you have any further questions, we'll put in the chat, email, contact details. Yeah. Fergus, did you want to add anything?
I think it's just to echo again, the assist, sometimes if we're newly exposed to it, we need to practice it. And particularly on the online platform using our phones, we just need to get used to the interface. So have a look at it, start implementing it in your workspace and take it from there.
Yeah, I'm just gonna give the questions another browse just for another minute and see if we can answer that. There's a question from Mahaja Rafiq. Fergus, I think this one is for you. It's a comment. There's a fine line between using psychoactive substances and being at the risk of dependency and addiction. How do we mitigate the risks? That's the question.
There's a fine line between using psychoactive substances and dependency. So I do think that there's thinking about, so you spending some time thinking about, are you able to moderate your usage and what are your stoppages? And then how the substance might impact on you, and getting either yourself or getting your client to think about how the psychoactive substance might be impacting on their functioning. And then I think that there's an important ratio to understand. It's 75 25 5. 75% of people who use psychoactive substances use it recreationally and they might never encounter any issues. 25% of people might abuse them around times that they have emotional or struggle or crisis, and those people just need some guidance as to they can use psychoactive substances more effectively. 5% of people who use that develop a dependency or addiction. So it's a much smaller number, and I think the way in which a treating professional clinician can best serve this sort of population is by upskilling in evidence-based treatment approaches, like the SBIRT model and motivational interviewing, etc. So have a good look at your universities around you and see if they provide services that upskill in these approaches.
Thank you for that response, Fergus. I'm just going to check if there's another 1 or 2 questions. I again apologize for the echo earlier. I saw people were saying that it was a challenge. And then Fergus, some people have also said they just reiterated that they use the cage, they use the assist, they use the task 10, and then there are some people who are saying they don't use any of these screening tools. I'm just checking for another question. Is nicotine and caffeine considered as a drug? Is there always psychological and physiological symptoms?
Yes, so there's always psychological, physiological response to ingesting the drugs. They considered a substance use disorder if they impair functioning. So there's low risk for the vast majority of the population when they are ingesting caffeine or nicotine. But the reason why we utilize the caffeine every day is that because it might help our focus or might help our productivity. So the drugs, the psychoactive substances definitely function. We just have to have an honest look at ourselves if that it impairs our functioning. So if we drink too much coffee and we're not able to sit down and do that piece of work that we need to, then that's. But yeah, have a good look at the criteria and have a good honest conversation with yourself.
Yeah. Okay, and so just another couple of comments that I'm going to read out. So in Scotland, they're saying benzos are particularly an issue, and then also heroin, crack cocaine, and then fun fact, Fergus, marijuana cannabis is called weed in Ghana. I didn't know that. That's interesting. I'm trying to see if there's any other fun facts that I can share with everybody. I think also just this, people just also reiterating that in South Africa, Nayope and meth amongst the youth is a problem, and alcohol, all ages, is a problem. Oh, there's one last thing. Magic mushrooms, there's a question, are they addictive?
I have not necessarily seen magic mushrooms in the treatment setting. So people don't usually get admitted to receive treatment on magic mushrooms. Although when people ingest magic mushrooms, it can induce perceptual or psychoactive changes or perceptual changes that they can act in a way that's irresponsible without any judgment. For example, wanting to swim to the middle of a dam or a lake at a festival, and then that might get them into trouble. So it's the episode once the magic mushrooms are ingested that leave the person vulnerable, but you're not really likely to see someone in treatment for magic mushrooms.
Yeah, thanks for that, Fergus. And then one last fact. In Zimbabwe, there's motoriro, a stimulant. I'm not sure what that is, but hopefully next week the participant can maybe tell us what it is. But yeah, thank you everybody for your questions and comments. We really appreciate that. We will, from the ITTC side, we will ensure that the video link is shared after this webinar series, so that people who did not get to watch it can watch it. And yeah, Rudolph, I'll hand over to you.
Thank you, Shahima and Fergus. This was a very informative and interesting discussion. And it was a real pleasure to have you with us today. Would also like to say a thank you to Dr. Goodman Sibeko from the ITTC. He played a key role in the organization of this webinar, and we are looking forward to part 2. So this webinar series is a clear example of the synergy in our collaboration between, that is the collaboration between ISSUP and ITTC. Shahima, can you remind us about the date for the part 2, the second session?
So the second session will be the same time. It will be 1 p.m. South Africa Standard Time, and it will be next week, Thursday, the 30th of November.
Okay, thanks for that reminder. So this officially concludes the webinar, and as a reminder, you receive a follow-up email within 24 to 48 hours with your certificate of participation and a link to view a recording of today's webinar. So on behalf of ISSUP, ITTC, and our presenters, thank you for joining us today, and enjoy the rest of your day.
Thank you, everybody. Goodbye.
Thanks, everybody. Thank Radolf. Thanks, Shahima.